Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagapet. We are discussing about the acute occlusive arterial disease. Acute occlusion to the arteries can occur due to an embolus or due to a thrombus on a pre-existing erythematous plaque. Sometimes it can be due to air, it can be due to fat, or it can be due to amniotic fluids. Of course, these are the emboli, types of emboli. The commonest emboli is thromboembolic phenomena. So we have seen what will happen if there is acute obstruction. So if there is pre-existing erythematous plaque is there, so there would be or there was already some partial occlusion due to the erythematous plaque. That is why there will be already development of some collaterals. So the clinical features are not so severe in such a case if thrombus occurs for the plaque. But if it is due to an embolus blocking the vessel, then the effects will be more serious and grave. Any intervention must be done within 6 hours. If you delay for more than 6 hours, there will be chance of getting gangrene of the limb. The main events that occur are the primary and secondary. Primary event is obstruction and causing distal ischemia. Secondary event is due to the obstruction, there will be stasis of blood flow in the proximal segment and distal segment of the vessel up to the branching vessels. This stasis causes thrombosis. So there is an embolus and there is a thrombosis. So this thrombus is called the propagated clot. So there are now two mechanisms of blockage. One is by embolus, the other is by thrombus. Now let us study the management. Immediate heparinization. What is the role of heparin in blood clotting? Will it prevent clotting or will it lyse a formed clot? Then you can understand why heparinization is done immediately. Once a patient comes to you with acute severe pain, with pallor, pulselessness, palsy, then you must suspect acute vascular occlusion. Then immediately you must give him the heparin. So what is the action of heparin on the blood coagulation system? Does it prevent thrombosis or does it cause lysis of the preformed clot? If it lyses the clot, it is called the thrombolytic agent. If it prevents, it is called anticoagulant. Very good. It is only to prevent thrombus formation. So when a patient with acute vascular occlusion comes to you, it can be due to an embolus or a thrombus blocking the vessel. Then what is the need for giving heparin? Immediately. Just think about and tell me. It is only for prevention of clot formation. Already clot is there. It has caused the occlusion. Then why you should give heparin now? Is there any use for that? What do you call that further coagulation? to prevent formation of propagated clot. So we have seen that whenever there is an acute occlusion by a thrombus or an embolus, there will be propagated clot both proximally as well as distally up to the branches. So that propagated clot should be avoided. Otherwise, your treatment will become more cumbersome and the effects of occlusion will be more severe. So heparin 5000 units is given intravenously to reduce the extension thrombosis. This is called extension thrombosis or propagated clot and maintain the patency of the distal vessel. Sometimes if the distal vessel has no branch, then the whole vessel may be occluded with propagated clot. So even though you remove the embolus, there is no use. Then you can use thrombolytic agents. That means which lyse the clot. Streptokinase, urokinase, tissue plasminogen activator. So these are the drugs. So these drugs are given to lyse the already formed clot or embolus. Tissue plasminogen activator is the preferred drug that is called TPA because of its rapidity of action and freedom from side effects. Indications: mild ischemia where immediate surgery is not required. In case of thrombosis, procedure, arteriography, and catheterization of the blocked vessel and infusion of thrombolytic agent into the clot. That means the TPA has to be instilled at the place where the clot is present. So how to reach there? So that is why you must do a arteriography. You must do arteriography to visualize the blocked vessel. Then you must pass a catheter by Sellinger's technique to the place where the clot is present and infuse the TPA at that place. Then the clot will lyse. Afterwards, you must check by serial arteriograms to check for the lysis of the clot. Contraindication: bleeding diathesis, pregnancy, and recent myocardial infarction. If the block is severe, ischemia is severe, then the streptokinase may not be of help. You have to go for surgical intervention. Open method, that means you expose the vessel which has the blood clot in it and remove the clot. So this is called embolectomy or thrombectomy. For example, a clot is there at the bifurcation of the aorta. Usually, this embolus will stop at bifurcations. So it will stop at, let us say it is here. Then what to do? You have to do laparotomy. Push all the balls to one side. Peritoneum will be there, posterior parietal peritoneum. So you separate, incise the posterior parietal peritoneum, enter into the retroperitoneal space, expose the aorta. Where the artery is blocked, you expose that area, then open it. So all these things must be done within 6 hours. Otherwise, both limbs will undergo gangrene. So, and actually a person with this type of blockage, where both limbs have been ischemic, there will be severe shock also. Because the blood in this vascular system is not coming into the circulation. It is being suddenly stopped. So there will be loss of cardiac, a decrease in the cardiac output. So the patient will be having hypovolemia and shock. So such a patient is not suitable for surgical intervention. So in those cases, what you do is and there will be propagated clot up to the renal vessels. Downwards, there will be propagated clot up to the iliac vessels. So in these cases, what you can do is you can go for a closed method without opening the abdomen. This is called Fogarty embolectomy. What you do here is the femoral artery can be exposed. It is palpable at the hip. So just below the mid-inguinal point of the inguinal ligament, if you deeply press your fingers, you can feel the femoral pulsations. So feel the femoral pulsation and pass a needle into it. Through the needle, you pass a guide wire. Under fluoroscopic control, the guide wire is passed beyond the clot because the guide wire can penetrate through the clot and embolus. So you pass beyond that, and over the guide wire, you introduce a catheter like this. This is called Fogarty catheter. This is an arterial catheter because the catheters to pass in the arteries, they must be made of special material so that they do not clot. So whenever you pass a catheter, there will be foreign body reaction and platelets will come and agglutinate. So these are all the specialized catheters called the vascular catheters. So when you pass them into the vessels, they do not promote thrombosis, and clot will not come and form over this because they are not irritant to the blood vessels and they do not attract platelets. Okay, this is the arterial catheter with a balloon at its tip. You can see the balloon. The balloon can be inflated or deflated at will. So if you want to inflate, you can inflate. You can deflate it, you can deflate it. So over the guide wire, you pass this catheter. Now the catheter is passed beyond the propagated clot in the aorta. So once the balloon is inflated, once the catheter is passed, you inflate the balloon. Then you just pull the catheter out. Once you pull it out, the whole embolus and propagated clot will come out. And for the other side, you repeat the same procedure from the other femoral vessel. So it takes only about 15 to 20 minutes, and this can be done even the patient is in shock. So this is a very simple method to do the embolectomy. This is called Fogarty method of embolectomy or closed method. So any clot or any embolus anywhere can be removed with this particular Fogarty catheter. With the help of Fogarty catheter, the embolus larger in the bifurcation of the aorta is extracted by passing the catheter through the arteriotomy in both femoral arteries. Fogarty catheter is also used to extract extension or propagated clot. So if the propagated clot is there, the whole clot can be extracted. So you pass the catheter till the end of the propagated clot, inflate the balloon and gradually extract it. Complications of revascularization of the limb. So once you remove the embolus and thrombus, the blood flow to the ischemic limb will be restored. So this is called revascularization phenomenon. Reperfusion injury. Acute vascular occlusion causes ischemia of the capillary circulation. So when the vessels are blocked for a time, then all the capillaries, they are deprived of blood flow. So when they are deprived of blood flow, they are deprived of oxygenation and nutrition. So they will be under anaerobic metabolism. So in that anoxic state, the capillaries will lose its integrity and they will shrink in size. The endothelial cells will shrink in size. So that's why there will be wide capillary pores. So any ischemic capillary will develop wide capillary pores. Now when revascularization is done or reperfusion is done, due to reperfusion of these dilated capillaries, fluid leaks into the tissues with edema of the muscles. So because there are large pores in the endothelium, so now the fluid will seep from the capillaries into the muscles, causing a lot of edema. So this may cause compartment syndrome with muscle necrosis, crush syndrome, and oliguria. So this will cause a phenomenon of crush syndrome. So deep fascia is there tightly. The muscles are expanding inside. So the deep fascia will not permit the muscles to expand because it's tight fascia. So the muscles are subjected for compression. So or they are subjected for almost like crushing. So this crushing will lead to liberation of myoglobin from the muscles. This myoglobin now will enter the blood circulation and they go into the kidney filtered and blocks the renal tubules, causing renal tubular necrosis. This is called crush syndrome. So in the peripheral compartment syndrome, we have studied about abdominal compartment syndrome. Similarly, there is peripheral compartment syndrome. Whenever muscles are subjected to crushing injury or tight pressure in a compartment, for example, take the leg. Leg is having the tibia and there are three compartments. The anterior compartment or extensor compartment, lateral compartment or perineal compartment, posterior compartment or flexor compartment. So these are all having septae and tight fascia around. So when the muscles swell there, they are unyielding. So they cause compression of the muscles with damage of the myoglobin, which is being released into the blood circulation, causing oliguria. So this is called Heimowsy triad. There is muscle necrosis, crush syndrome, and oliguria due to reperfusion of the ischemic limb. Next is the air embolism. So it seems Santi has a doubt about fluoroscopy. Now, you know about X-ray. You keep the patient under the X-ray tube and opposite side there will be X-ray film, and when the technician switches on the switch, so the X-rays pass through the patient and cast the shadow on the film that is there in front. You have to take out the film and study it. You have to develop it, then you can see the film. That is plain X-ray. But when a X-ray video camera is installed in front of the patient and X-rays are beamed from behind, then what happens? The patient's X-ray will be captured by this camera and that camera will demonstrate the image on your screen. So for example, if the patient is under this fluoroscope, this is called fluoroscopy. So if you move the hand like this, the skeleton of hand will be moving there on the screen. So whatever that is there, radio opaque, you can see moving. So if you're passing a catheter, so you can see the catheter, how it is passing. So this is called under fluoroscopy control. Now, fluoroscopy was a old technique where a very different film is placed in front of the patient like fluorescent screen, and in the screen the surgeon used to look at the picture and then do the procedure. But now we have the very well established procedures. Now we have a C-arm. Probably if you go to the orthopedic department, you will see C-arm. So like a big C will be there. At one end, it will be generating X-rays, and the C will be there. In the C, the patient table will be there. So X-rays will be coming like this, falling on the patient, and the image will be collected by a camera, and that will transmit the image to a screen. So on the screen, the surgeon can see. So this is the CCTV cameras. So like that, now we have a lot of other procedures where you can screen the X-ray image, live image. That is the fluoroscopy control. But this is usually called as under fluoroscopy control. But nowadays fluoroscopy is not being done. It is only by CCTV cameras. Next is air embolism. Causes accidental entry of air into the venous system, like operations and injuries on the neck and axilla. Why? Only operations and injuries on the neck and axilla predisposed to air embolism, not on the lower limbs or on the abdomen. If a patient comes to you with an injury, that is a cutting injury, a cut injury of the neck, the immediate danger is he may die of air embolism. Not only from bleeding, but he will die of air embolism. Tell me how air embolism can occur in these patients. The same cut injury is there on the upper limb, or same injury is there on the thighs. The patient is not going to have air embolism, but only neck injuries have this problem. Why? No, I am not. I am asking why it reaches through subclavian or jugulars. No problem. Just I want to know why an injury to the neck causes air embolism. No, there is no injury to the apex of the lung. It is higher above, not at the base of the neck. The injury is at the mandibular level, let us suppose. There is a cut injury. Or when surgeon is doing surgical procedure on the thyroid, he may cut one of the veins and patient may get air embolism. Why? Okay, then I will ask another question, an indirect question to make you answer. What is the pressure of veins in the neck? A person is sitting like me. So what will be the pressure in the internal jugular vein? For example, at the angle of the mandible. What will be the pressure? You can tell me approximate pressure, not the exact pressure. Okay, if you don't know it, okay. Ah, I am asking pressure in the veins, not in the arteries, same thing. Okay, I will give the answer. I will give the answer. It is not 2, 3, 4, 5, 6, 7, 8. It is minus. It is negative pressure. You calculate the distance in centimeters from the mandibular sterni or sternal angle to the place where injury is there. For example, this is 5 centimeters. Then the pressure in the vein at this place will be minus 5 centimeters of water. So above the heart, the pressure in the large veins will be negative side. Below the heart, that means when the person is erect, the person is in supine position, then they will be 0. The person is Trendelberg position, that means head down position, then there will be plus side. So because a person, whenever you are operating with the patient, keeping the head end of the bed elevated and doing surgery on the neck, you must always be cautious about air embolism. If the veins are injured, they just suck the air and cause air embolism. So you must be very careful. So that's why some surgeons, they do not keep the patient in head up position during neck surgery. They keep the table flat. I also practice only a flat table. I do not elevate the upper end of the head end of the table. But it is advantageous to do surgery with head end of the bed elevated on the neck because negative pressure is there. So all the veins will be decongested. So there will be less bleeding if you do surgery with a head end elevation posture. That is why there is a chance of the air embolism. Okay. So accidentally entry of air into the venous system. Example, operations or injuries on the neck and axilla. Induction of artificial pneumothorax. Tubal insufflation test. Do you know about this test? Tubal insufflation test. What is this test? What is tubal insufflation test? Tubal insufflation test means for the diagnosis of infertility cases, you pass a catheter through the cervix into the uterus and connect this catheter to a outside bulb which can inflate air. So by pressing the bulb, air will be inflated into the uterus and this air will leak out through the fallopian tubes. So what you must do is you must keep a stethoscope over the right iliac fossa and later over the left iliac fossa. And when you hear, you will hear the bubbling sound. That is tubal insufflation test. This is done for cases of infertility to diagnose tubal or fallopian tube obstruction. So when you inflate more of air, sometimes this air can be absorbed into the peritoneal cavity and can produce the air embolism. Then laparoscopy. You know, during laparoscopy also, you inflate air into the peritoneal cavity. So because of this danger of air inflation into the causing air embolism, during laparoscopy, you do not inject air or oxygen into the peritoneal cavity. You do this procedure with carbon dioxide because carbon dioxide is soluble in the plasma. Oxygen is not soluble. Oxygen should be absorbed onto the RBC and should be carried. So suddenly if large amount of air is introduced into the arterial system, then the RBC cannot able to absorb all the oxygen. So the oxygen will be circulating in the blood as bubbles. So you must always go for carbon dioxide insufflation for during laparoscopy. Then during IV administration, when you are giving some saline infusion to the patient, so by chance, by any accident, if you inject air into the tube. So 100 ml can be fatal to the patient. Here, artificial pneumothorax. Artificial pneumothorax is nothing but insufflation of air into the pleural cavity to produce pneumothorax. So with this pneumothorax, what will happen? The lung will be collapsed. So in olden days, to give rest to the lungs in case of tuberculosis, so in the artificial pneumothorax olden days, to give rest to the lungs which are infected with tuberculosis, people used to do this procedure called pneumothorax. But nowadays it is not being done. Either in the pneumothorax or during laparoscopy, the air is absorbed into the blood vessels through the peritoneum. When intraperitoneal pressure increases due to air insufflation, because in laparoscopy you will inflate up to the pressure of about 14 to 16 millimeters of mercury pressure. So at that pressure, the air can be absorbed into the peritoneal cavity, peritoneum. From there, it can be absorbed into the blood vessels. If you just inject 5 ml or 10 ml, if the pressure is not much, difference is there, then there is no absorption. But if you give large amount where there is increased pressure inside the abdominal cavity, that will cause the pneumoperitoneum and air embolism. Pathology of air embolism. Air in the venous system. So if the air enters the venous system, what will happen? All that air passes into the right atrium. From there to the right ventricle. And once it comes into the right ventricle, it gets churned, because the right ventricle always pumps. So with this, what will happen? The air bubbles and blood mix together and form foam. And this foam floats up, and the foam floats and blocks at the pulmonary ostium. So there will be pulmonary artery occlusion. This will cause right heart failure. When there is shunt from right to left side of the heart, example foramen ovale, then air embolism of coronary and cerebral vessels can occur, and this is called the paradoxical embolism. So if there is any foramen ovale, normally if your heart is normal, then the air will be blocking only the pulmonary ostium. It won't go into the arteries. So there is no arterial obstruction. But if there is communication between the right and left hearts, then the air can enter from the right heart into the left heart directly. From there it can enter into the aorta, and from there it can reach the cerebral or coronary vessels and cause blockage of those things. So this is called as the paradoxical embolism. Clinical features of air embolism. So once the pulmonary arteries are stuck with air or foam, the patient will get suddenly dyspnea, tachypnea. The respiratory will become, normally is only about 15 per minute, it becomes about 30 or 40 per minute. Then there will be cyanosis. There is fall of blood pressure and rapid pulse rate. Why there is fall of blood pressure? Because there is no pulmonary circulation. So from the right heart, the blood is not completely going into the lungs. So the return into the left heart will be decreased. So when the venous return to the left heart is decreased, automatically the cardiac output falls. So to compensate that, there will be rapid pulse rate. Then there will be hemoptysis. Because already I told you, whenever there is blockage of a vessel, then there will be ischemia of the capillaries. This ischemia causes vasodilatation, as well as the vascular pores in the endothelium will increase in size. So these increased capillary pores, through that the blood cells will leak out into the lung cavity, and the patient will expectorate blood in the sputum. Treatment: the patient is placed immediately in Trendelenburg's posture. Do you know what is meant by Trendelenburg's posture? Trendelenburg's posture. Do you know? It is keeping the patient in supine position and keeping the head tilted downwards. As feet elevation and head downwards. This is called Trendelenburg's position. If you keep in the reverse way, that means feet are down, head is up, then it's called anti-Trendelenburg's posture. So patient is kept in Trendelenburg's position and turned to left side to encourage the air to pass into the lower extremities and float into the apex of the right ventricle. So patient should be kept in left lateral position with head down. Then what happens? The heart will be now like this. All the air or foam here, because foam always go in the anti-gravitational method. So the foam will collect here. To this opening, it goes into the atrium. From the atrium, because there is head and down and feet are up, so the air bubbles will pass into the lower limb veins. So the main vessels, that is the pulmonary circulation, is being restored. So this is the first aid measure you have to do whenever you suspect air embolism. When oxygen administration, mechanical ventilation, if this is not relieving, then you have to do percutaneous aspiration of right ventricle in serious cases. If the above are not successful, heart is open to suck out the air. Okay, before I go to the fat embolism, there is a doubt by Santi. I will clear that. In the start of surgery, we give how much carbon dioxide so that it won't get absorbed, and end of surgery we deflate so pressure decreases. She is talking about pneumoperitoneum. How to avoid air embolism in pneumoperitoneum created for laparoscopic surgery. Yes. During laparoscopic surgery, air will be inflated into the peritoneal cavity because the abdomen will be normal like this. There is no space inside. Everything is occupied by bowels and other structures. That's why even if you pass a telescope to look into the abdominal cavity, you will not be able to visualize. So you have to always make it wide like this. You must make it like a cavity. So how to do it like that? That is why, first of all, what you do is you pass a needle, and through this needle you inject air or you pump air. If you air is pumped, I told you already, at high pressures, the peritoneum will absorb it, and that causes air embolism. To prevent that one, carbon dioxide is chosen for insufflation of the peritoneal cavity. So at that pressure, carbon dioxide is absorbed into the bloodstream. So there is a pressure gauge will be there connected to the abdominal cavity. So whenever you are doing laparoscopy, you have a insufflator machine. This insufflator machine will be pumping air into the peritoneal cavity. And the same insufflator machine will have a pressure gauge. You can set the pressure. For example, you want to keep the pressure at 14 millimeters of mercury pressure. You 14 millimeters, you set it there. Then you connect the insufflator pipe to the needle that is connected to the abdominal cavity. So now air will be insufflated into the peritoneal cavity. Automatically, when pressure of 40 mm is reached, the air flow will be stopped there. And while you are doing surgery, some leak will be there. When you are moving the ports here, this side and that side, there will be some leakage of air will be there. So whenever air leaks from the ports, there will be reduction in the pressure. So automatically the air insufflator will pump the air. So once you finish the surgery, you expel all the air that is there in the peritoneal cavity, and then you close the ports. So at 12 to 14 or 16 millimeters of mercury pressure, the carbon dioxide absorption will be taking place, but that will be at a slow pace. At that slow pace, if the carbon dioxide is absorbed, then the plasma will absorb it. As long as plasma can dissolve carbon dioxide, then there is no bubbling. That means there will be no free air in the vascular system. If you increase the pressure to 20 or 30 millimeters of mercury pressure, let us suppose, then large quantities of air will be pumped into the absorbed into the peritoneum, and that may lead to air embolism. So you must have a monitoring to monitor the amount of carbon dioxide that is there in the plasma also. So when you are doing surgery, so there will be the anesthetist will be gazing over a monitor that is called capnometer. So how much of carbon dioxide is there in the circulation as well as in the expired air. So that gets monitored. So usually they monitor the expired air because amount of carbon dioxide that is there in the expired air is directly proportional to the amount of carbon dioxide that is there in the plasma. So that is connected to the anesthetic machine, and the machine will be telling how much of carbon dioxide is being expelled. So by that, the anesthetist will be warning. Carbon dioxide is more, if for example, more carbon dioxide is coming out means, then they will instruct the surgeon to reduce the pressure, to reduce the flow of carbon dioxide. That is how the air embolism is prevented. The main principle of administering carbon dioxide is mainly because it is soluble or dissolves in plasma. Oxygen is not soluble in plasma or water. So the pressure that is maintained in the abdominal cavity will be usually between 12 to 14 millimeters of mercury pressure. For example, a multiparous woman comes. She has a very lax abdomen. Even with small quantity of air, her abdomen gets bloated. In that case, you go for only 10 or 11 millimeters of mercury pressure. What you need is how much space you need. That space must be provided there in the abdominal cavity. So depending upon that one, you select the pressure gauge. For some young people, even small quantity of air injection, insufflation will cause high pressures because the abdomen is very tight. So whatever may be, you always go for only less than 15 millimeters of mercury pressure to be safe side. If you want to go still more high, that means when the space is where a large mass is there, space is not adequate. Then if you want to go for high level, then you should definitely have a capnometer to monitor the carbon dioxide output, and by that you must control. I hope this is clear to you. Okay. Now we'll go to the next topic, that is fat embolism. The fat circulates in the bloodstream adsorbed on the lipoproteins. So there are specialized proteins are there. They carry the fat molecules on them. Free fat is not there. So free fat can be there in the plasma due to multiple fractures where the fat in the marrow will be pushed into the blood circulation. Why the fat occurs in the comes into the circulation, free fats comes is we do not know. Probably due to embolism of adipose tissue or due to metabolic change causing aggregation of chylomicrons. Clinical features manifest on second or third day, that is thromboembolism, on second or third week, and air embolism immediately. So fat embolism features will manifest only on second or third day after the injury. Air embolism manifests immediately after the injury. Thromboembolism manifests second or third week after the injury. So fat embolism pulmonary type, there is tachypnea, cyanosis, right heart failure, presence of fat globules in the sputum. Cerebral type, patient will have disorientation, drowsiness, coma, pyrexia, retinal hemorrhage, petechial hemorrhages. Treatment of fat embolism, oxygen administration, mechanical ventilation. These two are must for any case of air embolism. Heparinization, low molecular dextran. Other forms of embolism, they are rare. Pyemic emboli, infected myocardic aneurysm or pyemic abscess anywhere in the body can cause emboli of pus circulating in the bloodstream. So whenever these emboli pass in the bloodstream, they can lodge at any place and can cause abscesses. Then parasitic emboli, ova of Taenia echinococcus and filarial sanguinis hominis, their ova can form emboli in the bloodstream. Malignant emboli, already we have seen in the carcinoma of the kidney as well as the cardiac myxoma, there will be formation of these tumor emboli. And one form of air embolism is Caissen's disease, also called as decompression disease. Occlusion of small blood vessels by free nitrogen released from the dissolved nitrogen in the tissues. What is this dissolved nitrogen and what is all this? The nitrogen which is there in the atmospheric air, it is an inert gas. You inhale it, it comes out. Only oxygen and carbon dioxide, they only get interchanged in the alveolar spaces. This nitrogen is only a carrying gas. It just goes in and comes out. But this nitrogen may be dissolved in the blood when the atmospheric pressure is very high. When the atmospheric pressure is high, automatically the nitrogen also is pushed into the alveoli and the alveoli absorb this nitrogen. So nitrogen is dissolved in the blood and tissues in persons working in compressed air chambers. It is released free when rapid decompression takes place, or in persons who ascend in aeroplanes to above 7620 meters height. Okay, if they go above more than 7 kilometers height in the sky, then there is a chance of liberating the nitrogen into the blood. And similarly, when a person who is there in air compressor chambers, if he suddenly decompress, that air is decompressed, then there will be bubbling of nitrogen in the bloodstream. Similarly, in the underground mines, the patients will be working deep in the mines. So in the mines, the depths, there will be more atmospheric pressure. So the nitrogen gets dissolved. After finishing the work, the patient, if he ascends up in a fast lift, So lift will be there moving fast. So when it is moving fast, then there is no time for the dissolved nitrogen to go out slowly. All of a sudden it bubbles out and it produces air embolism. So the bubbles will now occur in the blood vessels. So these blood vessels will be blocked with these bubbles and causes excruciating pain, muscles and joints. Neurological disturbances like paresis of extremities and sphincters can be there. Treatment, recompression and gradual decompression. Then oxygen administration. Prognosis, if spinal cord is not damaged, prognosis is good. Therapeutic embolization, already I told you about therapeutic embolization. Anyway, I'll tell you again. Embolization of selected vessels for therapeutic purpose to achieve ischemia of the concerned organs. So if any organ is bleeding, for example, liver is bleeding, there is a tumor in the liver and it is spontaneously bleeding, then you can do the therapeutic embolization. Procedure, arterial cannula is passed into the required vessel by Sellinger's technique, and any of the following agents are injected, like blood clot, gel foam sponge, plastic microspheres, stainless steel coils, cyanoacrylate glue. So when you inject these things there, the particular vessel gets blocked. So this is called therapeutic embolization. Just I will show you technique. First, what is Sellinger's technique I am telling. You pass a cannula into the artery, then you pass a guide wire. This is also done under image intensifier or fluoroscopy. Then cannula is removed. So the guide wire is there is passed into the aorta. Over the guide wire, you thread a cannula and you push the cannula, the arterial catheter will now go into the blood vessels. Then you remove the guide wire. Now you can see the arterial catheter is being guided into this is the aorta, here the celiac axis, this is the hepatic artery. So it has passed into the hepatic artery and whichever segment is bleeding into the blood vessel supplying segment, you can guide it under this image intensifier guidance. So for example, fourth segment is having the tumor with bleeding, then you pass the catheter into the fourth segment and then you can block the fourth segment blood vessel by injecting one of those things which already has been described. Then the blood vessel supply is cut off and the bleeding will stop. Indications, bleeding from GIT or urinary tract, AV malformations to block the feeding arteries. Then small aneurysms like splenic aneurysm, then tumors like hepatic tumors, renal tumors, then varicose veins of the esophagus. It is generally done as palliative procedure in patients unfit for major surgical procedures. Then chronic arterial occlusion. Any doubts? Okay, if you have no doubts, we will proceed to the chronic vascular occlusion. Causes of chronic occlusion. Guide wire is only just simple wire. First you pass the guide wire. The guide wire is a stiff wire. It is very fine wire. So you can maneuver it in the blood vessels. Over the guide wire, you pass a cannula or a catheter, arterial catheter. The catheter will pass over the guide wire because guide wire is there. Over it can pass. So the required place it will be sent. Then the guide wire is taken away. Into the catheter, you inject the gel foam or cyanoacrylate glue to block the vessel. Chronic vascular occlusion. Acute means there is sudden and complete occlusion of the blood vessel. Chronic means there is gradual, progressive occlusion of the blood vessel. What are the causes? The intramural causes. They are classified into organic and functional. Organic causes being degenerative, that is atherosclerosis, then arthritis, example Burgess disease, polyarthritis nodosa, diabetes and syphilis, then vasospastic diseases like Raynaud's disease, cold injury, ergot poisoning. So these are all the intramural causes for chronic vascular occlusion. Then extramural causes, that means outside the vessel, something can cause compression. Examples being tight bandages and splints, thoracic outflow compression syndrome. What is thoracic outflow compression syndrome? The structures that come out of the thorax will be occluded, like the subclavian artery. Along with it, the nerves also may be put to compression. That is called the thoracic inlet syndrome or thoracic outflow compression syndrome. Then compartment syndromes. So out of these so many causes, the common causes being there is a mnemonic or a tip to remember: Raynaud's, embolism, senile, that is atherosclerosis, T for thromboangiitis obliterans or Burgess disease, thrombus, ergot, and diabetes. Pathology. So whenever the vessel is being progressively blocked, so when vessel is there, when it's being gradually getting occluded, so there will be 10% lumen is blocked, then 20%, then 30%, then 50%, then 70, then 100%. So in the initial stages, there is mild ischemia. And for example, 10% of the vessel is blocked. I'm not just giving just an approximate figure. If, for example, 10% of the lumen is blocked, then there may not be any ischemia. The patient may not feel any symptoms and signs of ischemia because 90% of blood is flowing. In our body, there is a lot of reserve capacity. A person who is sitting, he requires such certain quantity of blood in the muscles. If the person is walking, he needs more amount of blood. If the person is running, he needs still more. If he is running at a fast pace, then he requires more amount of blood. So when such amount of blood is being passed, the blood vessels should be able to relax, dilate, and supply the blood to the muscles. So that reserve is there for the blood vessels. When 10% of the blood vessel is blocked, then the patient will not have the features of ischemia while he is taking rest. But if the fellow is running, then the patient will have the symptoms. This is called on demand. So when there is demand for more blood, the blood vessel is not able to supply. This is called on demand ischemia. If it progresses to 50%, then there will be stage called stage of pre-gangrene. If it progresses to 100%, there is stage of gangrene. So what is chronic mild ischemia or on-demand ischemia? So chronic ischemia, inability of the muscles to get adequate blood during exercise. During exercise, the muscles cannot get sufficient amount of blood. So what they do, they go into anaerobic metabolism. By that, the anaerobic metabolites are produced in the muscles. And these anaerobic metabolites cause pain in the muscles. So they are toxic, that is, they produce a lot of pain in the muscles. So whenever pain is there, the person will first limp for some time, and afterwards he will be forced to stop walking. Then he takes rest. On taking rest, the blood supply to the muscles become adequate. Then muscles again resume aerobic metabolism and the pain producing substances are cleared. So pain is relieved. So the future of on-demand ischemia is pain produced on exercise and relieved after taking rest. So this is called as claudication pain. This is called intermittent claudication. What is the meaning of claudication? The word is derived from Claudius. In Latin, Claudius means limping. Just imagine you are sitting in the balcony of your house and you are looking at the road. A fellow is walking. So he walks for some distance. This fellow is having chronic mild ischemia. So he walks for some distance. Then, after some time, what he will do is he starts limping. Then he stops walking. He sits somewhere or stand idle like that for 3 minutes or 5 minutes. Then again he starts walking. Then again he stops. Then again he starts walking. So there is intermittent limping. The limping is because of pain in the muscles. So that is why it is called as intermittent claudication. So intermittent attacks of cramp-like pain in the muscles produced after exercise. It is not present on taking first step. So when the patient has started his walk, there is no pain. Only after walking for some distance, he gets pain. In case of osteoarthritis, also there is pain on walking, but the pain starts immediately after taking the first step, not after walking for some time. So that is where you can differentiate. Then pain is relieved after taking rest within 5 minutes. Within 5 minutes, the pain is relieved. There is another condition called neurogenic claudication. The pain is relieved only on sitting for more than 5 minutes. Depending upon the severity, the mild ischemia is graded into 3 grades by Boyd. That's called Boyd's classification. Grade 1, patient is able to walk continuously in spite of ischemia as the pain is mild, and the pain is relieved as the increased perfusion of muscle due to exercise washes off the P substance produced by ischemia of the muscles. In the early stages of ischemia, there will be some pain, but in spite of the pain, the patient will be able to walk. And the anaerobic metabolites that were produced, they will be washed away. Why? Because the anaerobic metabolites produced are the lactic acid and pyruvic acid. They are all vasodilators. So they cause local vasodilation of the muscle system, and that will cause augmented blood flow. So with this augmented blood flow, the pain producing substances are washed away. So the patient gets relief. This is grade 1. Grade 2 means patient continues to walk after the pain with effort. That means with limping he will be walking. Grade 3 means patient is compelled to take rest because of severe pain and resumes walking only after the pain subsides. The site of the pain depends upon the level of occlusion. The pain is felt in one anatomical level below the level of obstruction. That means, for example, if there is partial obstruction of the femoral artery in the thigh, one level below, that means he will get the pain in the leg muscles, that is calf muscles. For example, if the patient is having block in the calf muscle area, then patient will get pain in the foot region. The pain is there in the iliac vessels, then patient will get pain in the thigh as well as leg. So occlusion of popliteal or posterior tibial artery produces pain in the calf muscles. Femoral artery produces the thighs. That means upper femoral artery, but lower femoral artery produces pain in the calf muscles. Iliac artery produces pain in the buttocks. Then claudication distance. The distance needed to produce claudication is called claudication distance. It varies with speed of walk, uphill walk, head-on wheel, and hemoglobin percentage of the patient. Peripheral pulses are normally palpable but disappear on exercise up to the claudication pain. This is called disappearing pulse sign. Disappearing pulse sign is due to vasodilatation of the tissues and muscles on walking distal to the obstruction, reducing the pulse volume. So when there is a block, partial block is there because of the vasodilatation. So blood is being taken away. So there is pulse pressure will come down. This is called disappearing pulse sign. Differential diagnosis of intermittent claudication, osteoarthritis. Here pain is present from the beginning of the walking. Neurogenic claudication. What is neurogenic claudication? Due to some peripheral nerve problem, the patient gets pain on walking. So what is this neurogenic claudication? It's lumbar canal stenosis. That means whenever there is some narrowing of the lumbar canal, the nerves that comes out, they are put to some compression, like lumbar spondylosis or disc prolapse. So whenever the person is walking, so there will be compromised blood supply to that particular nerve. Because there is obstruction or pressure over the nerve, the blood supply gets impeded. That produces severe pain. So here, the pain will be there even after taking rest. Like in the muscle pain, the pain is not relieved after taking rest. So this is the way you differentiate between neurogenic claudication and intermittent claudication. Next is stage of pregangrene. The occlusion has gone up to 50%, let us suppose. There is impairment of blood supply to the muscles even during rest. Even during rest also, the amount of blood that is supplied to the muscles is inadequate. This produces pain in the muscles during rest also. That is why it is called as the rest pain. Then there will be impairment of blood supply to the skin and soft tissues. This causes paresthesia and skin color changes and later chronic ulcers. Clinical manifestations: rest pain. Pain is present even during rest. It is worsened by lying down or on elevation of foot due to loss of gravitational effects on the perfusion pressure in the foot. That means in the stage of pregangrene, the patient will have severe pain in the muscles. For example, there is obstruction of the femoral artery. The patient will have severe pain in the calf muscles. Even during rest also it is there. So because pain is there, he wants to sleep, or he wants to be on the bed. So he lays down on the bed supine. Pain is not in decrease. If he elevates the limb, pain gets aggravated. Whenever limbs are elevated, there will be vasoconstriction. Whenever limbs are on dependent position, there is reflex vasodilatation. So remember this point. So the gravitational effects on perfusion pressure will be there. This is because of gravitational influence on the blood vessels. So whenever limbs are elevated, there will be vasoconstriction. So there is still more decreased blood supply producing aggravated pain. So the person learns that whenever his foot is in dependent position, that means if he sits in a chair, the pain is less. When he lies on a bed, pain is more. So pain will be less on dependent position, more on elevated position. So it is relieved by hanging the part down. Example, sleeping in a chair. So the patient prefers to sleep in a chair. Then skin changes, color changes. You can see here, there is gangrene here distally. Proximally, there is erythema. Why this erythema is here? Just imagine and tell me why there is erythema. Why there is vasodilatation? This is a occlusive arterial disease. Why there is vasodilatation? Yes, very good, Nizami. It is due to capillary damage. I will explain. Any erythema represents normally vasodilatation. Why vasodilation occurs here in occlusive arterial disease? It can be due to infection. Because there is gangrene here, there may be ulceration, there may be entry of bacteria, and that may cause infection. So due to infection, there can be erythema. But in gangrene or in vascular ischemia, it is due to ischemia of the microcirculation. The blood vessels and the capillaries, they are deprived of oxygen because of the reduced flow. So what will happen? The pores become widened. Initially, they permit fluid to come out. Later, there will be extravasation of RBC. So the RBC come out of the capillaries and they will be in subcutaneous tissues. And that causes this red discoloration. If it is due to inflammation and vasodilatation, if you press it with your thumb and leave the thumb, you will see blanching because the dilated vessels are being compressed. So you will see blanching. If it is fixed discoloration or if it is due to capillary ischemia, it is due to hemoglobin that is being deposited in the subcutaneous tissues. So even if you press it like this, there is no change in the color. The color will be permanently like that. So that is called fixed discoloration. So fixed discoloration is where the color doesn't alter on pressure of a thumb, or the color doesn't alter on elevation or on dependency, because this is due to RBC extravasation into the subcutaneous tissues through the capillaries. So early phase, pallor on elevation and purple discoloration on dependency is seen. Severe ischemia, pink color which doesn't blanch. It is due to extravasation of RBC through ischemic capillaries. So stage of pre-gangrene means there will be rest pain, there will be color changes. Initially there will be pallor on elevation, then pink color on dependency. Later there will be fixed discoloration. Next, the other features being ulceration. Chronic small indolent ulcers around malleoli, dorsum of foot and interdistal clefts. So on the dorsum of the foot, around the malleoli and interdistal clefts, first there will be ulceration. Initially there will be discoloration, later that discoloration will lead to formation of an ulcer. The area of the ischemic limb feels cold. There will be paresthesia and numbness, but motor paresis is not present. Acute ischemia causes paresis, chronic ischemia doesn't cause paresis. So this fellow is getting an interdistal cleft ulcers here. On examination, there will be absence of peripheral pulses. What are the peripheral pulses to be examined? Dorsalis pedis, posterior tibial, popliteal, femoral in the lower limb. Radial, ulnar, brachial, axillary and subclavian in the upper limb. Carotids in the neck. Then abdominal aorta. So any case of a vascular ulcer, ischemic ulcer, you must examine all the peripheral pulses in the body. The patient comes to you with an ischemic ulcer on the foot. Don't confine yourself only to the foot vessels. Examine all the rest of the peripheral vessels also, because the ischemic ulcers are produced by vascular occlusion. Some of the occlusive arterial disease are generalized occlusive arterial diseases. Example, atherosclerosis. Though the symptoms and signs are manifesting in one part of the body, there may be occlusive disease at other places also. That is why you must examine all the peripheral pulses in the body. So this is the carotid artery pulsations. You start with the superficial temporal artery, where it is felt just below, in front of the tragus of the ear. And this is the anterior branch of the superficial temporal artery. You will feel over the orbital margin. Then carotid pulse is felt in front of the sternomastoid. If you keep your fingers here, you can feel. Then over the lower part of the mandible, you can feel the facial artery, the branch of the external carotid artery. Then upper limb pulses. You can feel the upper limb pulse in the axilla by passing your fingers deep into the axilla and pressing them against the humerus. You can feel the axillary artery pulse. Over the medial side of the arm, you can feel the brachial artery pulse. Similarly, in the cubital fossa, also you can feel the brachial pulse. The ulnar artery pulse is felt just lateral to the flexor carpi ulnaris tendon. Flexor carpi ulnaris tendon. Just medial to the flexor carpi radialis tendon, over the front of the radius at the lower end, you can feel the radial artery. Abdominal artery, aorta, you can feel it just below the umbilicus where it bifurcates, or below the giphisternum. The lower limb vessels, the femoral artery is felt below the midinguinal point of the inguinal ligament. Popliteal artery is felt by making the patient to flex the knee, and then you feel in the popliteal fossa. Dorsalis pedis artery is felt over the tarsal bones just lateral to the extensor hallucis longus tendon. The posterior tibial artery is felt midway between the medial malleolus and calcaneal tuberosity. So midpoint between them, if you keep your fingers, you will feel the posterior tibial artery pulsations. Then arterial bruit. Systolic bruit may be heard over the stenosis vessel. A machinery murmur is heard over the AV fistula. I hope all of you know in the clinicals, ulcer is a very important case that is given to you. So whenever a ulcer is given to you, you must evaluate the cause of the ulcer. Is it due to ischemia? Is it due to neurological cause, like anesthesia produced due to neurological damage? Is it due to venous engorgement or varicose veins? So arteries, veins, nerves, they can cause ulcers. Or it can be due to an infection, or it may be due to post-trauma, or it may be due to syphilis or tuberculosis. There are specific infections. Sometimes there will be no cause. There is non-specific ulcer. If it is a ischemic ulcer, that means it belongs to pregangrene stage. In the pregangrene stage, you must see for all these things what I have said. Examine the ulcer and describe the ulcer. Then inquire about rest pain. Look for the skin color changes, fixed discoloration. Feel the pulses all over the body and record which pulses are weak or which pulses are absent. A person may have ulcer over the dorsum of the foot. Then you may not be able to feel the pulses in the foot, in the popliteal fossa, and in thigh also. That is why you must examine all the peripheral pulses. Venous refilling. In a normal person, if the limb is elevated and laid flat, veins get filled within seconds. So just elevate your upper limb, so the veins gets emptied. Once you keep it down, the veins become again full. In vascular insufficiency, reduced or delayed venous refilling takes place. Stage of gangrene, usually dry gangrene with dry mummified black extremities. Wet gangrene if there is associated venous occlusion. You can see the examples of dry gangrene. So this is about chronic vascular occlusion. So it can be in 3 stages. First stage is stage of intermittent claudication. Second is stage of pregangrene. Third is stage of gangrene. So as the occlusion is gradually progressing, the patient passes from one stage to the other stage. So investigations, general investigations and regional investigations. General investigations aim to evaluate vascular supply of vital organs, especially heart. So whenever you diagnose vascular insufficiency, there may be vascular insufficiency to the viscera also. So you must evaluate vascular supply to the vital organs. To assess the predisposing arterial diseases, certain diseases predispose, like diabetes mellitus, and aggravating diseases like anemia. So blood studies, hemoglobin percentage to examine for anemia or polycythemia, lipid profile, glucose estimation, fibrinogen estimation. Then you go for cardiac assessment with ECG and treadmill test. So those are general investigations you do. General investigations are mainly to know about the blood coagulability status, predisposing factors like hyperlipidemia and hyperglycemia. Regional investigations aim to diagnose presence of arterial insufficiency where present or not, the level of obstruction, and severity of the obstruction. So the non-invasive, first of all, we classify them as non-invasive and invasive investigations. The non-invasive investigations, Doppler ultrasonic blood flow detection. So this is called the Doppler flow meter. You can see here the fellow has kept the probe over the dorsal respiratory artery. So it gives an audible signal. When you keep the stethoscope here, you can't hear pulsations. Only when you check for the blood pressure, then you will hear the pulses up to the diastolic pressure. Once diastolic pressure is reached, then you can't hear the pulses or you can't hear the sounds of the pulse. But Doppler ultrasonic probe, if a pulse wave is there, then you will hear the pulse wave as audible signal. Doppler ultrasound probe is used as a sensitive type of stethoscope to record blood pressure and bruit in small vessels. Ankle brachial blood pressure index. That means first you record blood pressure at the arm, then you record the blood pressure at the ankle level. So the ratio between the ankle blood pressure to brachial blood pressure is normally about 1.0. That is, they are equal. If the ratio is less than 0.9, that indicates arterial insufficiency to the lower limb. If it is less than 0.3, severe ischemia. So you can quantitate the amount of obstruction with this Doppler ultrasound probe. So this is the first preliminary investigation you do about the vascular study. The next investigation is called the duplex imaging. Duplex means it is an ultrasound with Doppler effect. So both will be combined. Duplex scanner uses beam mode ultrasound and Doppler ultrasound to map the blood vessels and blood flow in them. So you can see the images of the blood vessels like this. You can calculate the amount of blood flow with this duplex imaging. The ultrasound waves are beamed at the blood vessels and the movement of blood cells causes a change in the pitch of the reflected sound waves. So first you beam ultrasonic waves at a blood vessel. So these sound waves, they are reflected back. So how they are reflected back, that depends upon the speed of flow. So there will be change in the pitch or frequency of the sound wave that is reflected. That is called the Doppler effect. So by the Doppler effect, you can identify the flow, how much flow is there. So a computer collects and processes the sounds and creates graphs or pictures that represent the flow of blood through the blood vessels. Then MRI angiography and CT angiography. These are all the non-invasive investigations. So you can see here, this is an MR angiogram. On the left side, there is normal iliac vessel, and there is normal femoral artery. This is the profunda femoris artery, and it is going into the thigh like this. But here you can see the iliac artery, there is block. But the distal vessel is filled. How the distal vessel is filled? Because of the collaterals. So the dye has come through the collaterals and filled this. And through the collaterals, it has passed into the profunda femoris. From there, they passed into the main femoral artery, and femoral artery is filled. So I can actually image the vessels here. It is gradually replacing the arteriography. It is done where duplex scanning is not feasible. The leg intrathoracic vessels or produce poor images, example in aortoiliac vessels. So duplex scanning is preferred. Why? Because it is simply easily available. It can be done by any sonologist. And it is cheap. But MRI angiogram or CT angiogram, they are very costly and they are available at only few centers. The subtraction of other tissues can be done, rendering the vessels more accurately. Now you are seeing in the MR scanning here the muscles and other tissues here. With computer technique, what you can do is you can take away all the other images, leaving behind only the vascular images. So this is called subtraction method. So by subtraction method or subtraction angiography, you can get clear image of only the vessels. So these are some of the examples of the CT angiogram. This is the coronary angiogram, and this is the abdominal aorta. This is the lower limb vessels. So if you do subtraction angiography, what will happen? All this femur and etc., they will be knocked down. You will not be able to see them. Here you are seeing all these things, but that will not be seen. As in the previous image, there is subtraction MR angiogram, where the skeletal shadows and soft tissue shadows have been removed. This is the cerebral angiogram. So you can only keep the blood vessels image and remove all the other images. That's called subtraction angiogram. These are all the examples of MR angiograms. You can see this is ordinary CT angiogram. This is CT angiogram after distal subtraction, the same image. You can see the aneurysm of the abdominal aorta. Underlying bone is seen here. That's why you're not able to appreciate the various vascular structures. So if you take away the bone image, then you can see the clear picture of the vessels here. So this is called distal subtraction imaging. So these are the non-invasive investigations. Now the invasive investigations, arteriography. It is done only if decided to operate on the vessels, if duplex angiography doesn't give vivid information. So this is example of aortogram. That means directly injecting radio-opaque dye into the blood vessels and taking the X-ray. This is the arteriography. Methods: direct method, indirect method. Direct method, the artery is directly punctured and radiopaque material is injected and radiographs are taken. This method is not performed nowadays. For example, you want to take the abdominal aortogram. So pass a needle from behind into the abdominal aorta and inject the dye into the abdominal aorta. That is a very difficult procedure. That is called the direct technique. That is feasible only for the vessels of the extremities like the upper limbs and lower limbs. You can feel the brachial artery here. So you can directly inject the brachial artery here. You can get a direct arteriography. The indirect method is called the Seldinger's method. So already I told you, you pass a cannula, through the cannula you pass a guide wire, over the guide wire you pass a arterial catheter. The arterial catheter is advanced into the place where you require to do the technique and you inject the dye there and get the shadow. Of course, I already told you about this technique, that's why I'm not explaining it here and here. You can see here celiac angiography, where you can inject the celiac artery and its branches are seen here. So this is the femoral arteriogram. This is the superior mesenteric arteriogram, where the dye is injected in superior mesenteric artery. Then superior mesenteric arteriogram, venous phase. If we wait for more than 20 seconds, then the dye will be taken up into the veins, and you will see the veins contrast material. And this is the carotid angiography, and this is internal carotid angiography and vertebral artery angiography. Already I told you about distal subtraction. In conventional angiography, the dye is injected in vessels and X-ray image is taken, which will show the vessels and other soft tissue and bony shadows. This will impair accurate visualization of the vessels. In distal subtraction, before the dye is injected, X-ray image of the part is taken and it is called the mask image. With an image intensifier, X-rays are taken after the injection of the dye for the same area, which will take all the images without the mask image, thus producing images of the vessels only. So this is a computer-aided technique. First you take the X-ray of the part before injecting the dye. So you get the skeletal and soft tissue shadows. Then inject the dye. You get the blood vessels. So with the computer technique, what you do is you subtract the first image from the second image. Then you get the blood vessels. Management. General management and specific management. General management. Only 25% of the patients with intermittent claudication progress to the next stage. Patients with ankle brachial pressure index of less than 0.5% are likely to deteriorate. Claudication is often a marker of silent coronary artery disease. So when a patient is having claudication, means he may be having associated silent coronary artery disease also. So you have to evaluate it. So these are all the statistics. 0.1% decrease in ABPI below 0.9 is associated with 10% increase in the relative risk of cardiac vascular disease. Hence, the aim of management of claudication is to reduce the risk of major cardiovascular morbidity also. Not only focus at the claudication. So whenever a person comes to the claudication, means he must be having associated coronary artery disease, which is silent. So you have to evaluate it and you have to correct it. Otherwise, he will end after the infarction. That means irreversible destruction of the myocardium. So general management principles are: stage of claudication, advice to stop smoking. So smoking adversely affects the arterial diseases. So you must strictly advise him not to smoke even a single cigarette. Reassurance. So you advise the patient assurance and reassurance, and advise him to have 2 hours of exercise per week. That means total period, minimum time of exercise must be 2 hours. Patients are reassured and advised to walk within the claudication distance to improve the collateral blood supply. So advantage of doing exercise is that promotes collateral supply, that improves the collateral circulation. So even if there is sudden occlusion, these collaterals will help to perfuse the limb. Control of diabetes, hyperlipidemia, and hypertension. These are the predisposing factors for vascular occlusion. Care of ischemic limb, protected from minor injuries due to pressure and friction. Heel rise. So patient is asked to walk with high heel shoes. So not only the females, where it is a fashion to have high heels, so even the males are advised to have the high heels. Why high heels? Is there any benefit out of it? Why high heels? What is the advantage? It is written here, it is to reduce the workload. When the person is walking, the heel has to be lifted up. So the heel has to be lifted up means if it is flat on the ground, the calf muscle has to work more to lift it up. Already if it is in lifted position, the calf muscle need not work. Then why this fashion of high heel came to the women population? Do you have any idea? Probably you don't have. In Western community, they will wear a dress where the legs are being exposed. Because legs are exposed, they care for the cosmosis of the leg also. For the females, if the calf muscles are very thick or very bulky, that gives a masculine look. That is why they want to keep the calf muscles thin and slim. That means there should not be any work hypertrophy of the calf muscles. Even if they work, that should not cause much workload on the calf muscle. So with that intention, the high heels has come as a fashion into the public. So because they want to have slim calf muscles, they use high heels. So ultimately, it has been turned to be a fashion to walk with high heels. So our people, they walk with high heels, not for the intention of making the calf muscle slim, but only as a mark of fashion. So if any person uses high heels, their calf muscles will come down. It becomes thin. The general management drugs, beta blockers used in hypertension therapy may aggravate claudication, so they should be avoided. So some other hypertension therapy should be given. Pentoxifylline tartrate, which reduces blood viscosity by making RBC more flexible, may be of help. Clopidogrel 75 milligrams per day or aspirin 75 milligrams per day reduces platelet adhesiveness and thereby increases the blood flow. Statins, they help to reduce the lipid levels and they stabilize the atherosclerotic plaque. That is why stabilize means it doesn't become loose. Sometimes when it becomes loose, that can produce subintimal hemorrhage and cause sudden death of the patient in case of coronary disease. So if you give statins, it stabilizes the atheromatous plaque. So the patient will not have that problem of subintimal hemorrhage. So any atherosclerotic plaque, if it is there, means it is always advisable to give statins, even though there are no hyperlipidemia. So they are given in normal lipidemia also. Vasodilators are not helpful. So that is general management. There is the drugs. Stage of rest pain. Non-narcotic analgesics like codeine and tramadol. Stage of gangrene. Once gangrene is there, you must do the amputation. Where do you do the amputation? The amputation must be done in the well-perfused proximal tissues, not at the border of gangrene. You must see proximally how far the tissues are perfused normally. So in the normal perfused tissue, you have to do the amputation. Otherwise, the stump will become gangrenous again. So these two groups, that means rest pain patients and gangrene patients, they require intervention to prevent major amputation. So they require some arterial surgery to reduce the level of amputation. Of course, in atherosclerosis topic, I will explain it again, you will understand it. Specific management depends upon the disease responsible for occlusive arterial disease. This is in general about the chronic occlusive arterial disease. So the pathology and clinical stages, the investigations, invasive and non-invasive investigations. Main investigation is Doppler ultrasound probe and ankle brachial pressure index. Next is the duplex angiography. These two must be done for every case of vascular occlusion. Where there is still some doubt, you can go for CT or MR angiography. Distal subtraction is more beneficial. Direct arteriography and indirect arteriography are reserved only for the patients whom you want to operate. In the management, there is no specific drug which will reduce the occlusion. So all the efforts are being done to stop the progression of the disease by asking the patient to avoid smoking. And the available collaterals, they must be dilated. So by asking the patient to do exercise within the claudication distance. Totally must have exercise for minimum of 2 hours in a week. The pre-existing diseases like diabetes, hypertension, cholesteremia, they should be controlled. Rest pain, you give analgesics, gangrene, do amputation. So that is general measures. Specific management depends upon the disease. We have seen atherosclerosis, Burgess disease, and host of other conditions. So the specific management is mainly aimed at those diseases. General management is same for every vascular occlusion. Specific management. Now let us study about the atherosclerosis. What is atherosclerosis? It is a patchy, degenerative process of the vessels, affecting the intima of the large arteries and some of the medium-sized arteries like coronaries, cerebral, renal, and mesenteric arteries. So these medium-sized arteries and large arteries, they are affected due to a degenerative process in the intima. This is a senile process. So this is a very natural process. But some individuals, they develop at an early age, at a faster speed, but everyone will ultimately have atherosclerotic changes in their blood vessels. If they are there at the crucial vital organ supplying vessels, they produce disability. If they are at some other place where they are not progressing much, they do not produce disability. This is how God makes the population to extinct after certain age, by gradually making the vessels narrow, and the structures and things will become progressively less vascular, and then ultimately leads to the death of the tissues and death of the person. So the age incidence is past 40 years, but now it has been observed that even at 20 years also the atherosclerotic changes can be there. So that's why even at your age, you must be having cautious about this atherosclerosis and take certain health precautions. Gender incidence is men and postmenopausal women. Heredity plays a very major important role. That means some individuals you see myocardial infarction. even at the age of 35 or 40 years. So this will be seen mostly in people with the hereditary or genetic factors. So there are certain genetic factors which make the atherosclerosis develop faster and at an younger age. Incidence is lower in people who regularly do the exercise. Right, high intake of saturated fat, associated disease like familial hypercholesteremia, myxedema, diabetes mellitus, giantomatosis, obesity, smoking. It accelerates the pathological events. It do not cause atherosclerosis, but it accelerates. So atherosclerosis is a natural process. I told you in some it won't cause problem, in some it causes problem. So that all depends upon the progression of the disease. The progression of the disease is influenced by these factors: lack of exercise, the diet, associated diseases, smoking. So these cause acceleration of the process. So we have seen the lipoproteins. So there are the LDL and VLDL lipoproteins. So what they do is, so they are taken up by the macrophages, and the macrophages, they form first linear streaks on the endothelium. They aggregate together and form a waxy coat over the intima. Later, it spreads to the media also. The elastic media and the muscle will be replaced by this plaque formation. And the body will respond to this by formation of fibrosis around it. So there will be fibrous capsule. And sometimes this plaque will be having calcium deposition. And as it is growing or protruding into the lumen, it will be causing blocking of the vessel. So it causes two things. Number one, because the elastic tissue is being replaced by this plaque, the elasticity of the vessel is lost, the vessels become thick. It may be localized like this, or it can be a diffuse. The whole vessel may be involved, which may be having just wax-like plaque, or fibrous plaque, or calcified plaque. And because of this plaque, the platelets will come and agglutinate and form a thrombus. Sometimes this plaque can separate, and when the plaque separates, blood flows under this plaque, and that is called subintimal hemorrhage. Whenever there is subintimal hemorrhage, because there is sudden lifting of the plaque, so it will be lifted up and causes complete occlusion. So in atheromatous plaque, there will be chronic vascular occlusion. Sometimes it may be precipitated as acute obstruction when a thrombus forms over it, or when there is subintimal hemorrhage through a crack or a fissure in the intimal plaque. So wax-like plaque on the intima of the vessel, this can be calcified, it may form an ulcer over which thrombus can form. This causes chronic occlusion. Subintimal hemorrhage and thrombus on the plaque can cause or precipitate acute vascular occlusion. The vessels affected being in the lower extremity, aortoiliac, iliofemoral, superficial femoral, arteries below the knee are not affected. So these are the commonly affected vessels in the lower extremity. Then upper limb, subclavian vessel. In the neck, common carotid artery, origin of internal carotid artery. Then coronary arteries, cerebral arteries, middle cerebral is commonly affected, renal arteries, and mesenteric arteries. So these are the structures that are affected. Clinical features: lower extremity. Already we have seen that clinical features will be intermittent claudication, features of pregangrene, and features of gangrene, depending upon the progression of the obstruction. So if the obstruction is there at the bifurcation of the aorta, so when the plaque occurs at the bifurcation of the aorta, it is called as the Lerich's syndrome. This is one of the frequently given question in the theory examination as short notes. So what is the Lerich's syndrome? It is nothing but atherosclerotic plaque formation at the bifurcation of the aorta. So when the bifurcation of the aorta being affected, what will happen? There will be decreased blood supply to both the lower limbs. So the patient will have claudication pain in the buttocks because iliac vessels are affected and both lower limbs. On examination, there will be absent femoral and distal pulses bilaterally, and there will be impotence because blood supply to the penile structure is being obstructed. Then iliac artery obstruction. There will be claudication of the affected thigh and calf. So if the affected side, the patient will have pain in the thigh as well as calf and sometimes in the buttock. There is absent femoral and distal pulses. Same as Lerich's syndrome, but it is only unilateral and there is no associated impotence. Femoropopliteal obstruction, claudication in the calf and foot, absent unilateral popliteal and distal pulses. Distal popliteal obstruction, claudication in the calf and foot, absent unilateral ankle pulses. Upper extremity, the clinical features may be asymptomatic. There may be claudication pain in the upper limb, rarely gangrene of digits due to embolization from the thrombus, or there may be a condition called subclavian steal syndrome. Again, this is an important short notes question. Subclavian steal syndrome. So whenever there is obstruction to the subclavian artery due to atherosclerotic plaque, most of the patients, they are asymptomatic because of good collateral circulation around the shoulder between subclavian artery and the axillary artery. Or the patient may have claudication pain in the upper limb. Whenever a patient uses the upper limb, he may get pain. Rarely, there may be gangrene of the digits due to embolization from the thrombus. It is not mainly because of thrombus, because thrombus, even if it is there, there is good collateral supply, so the limb ischemia is not there. But sometimes this thrombus may dislodge emboli, and those emboli may go to the digits and may cause obstruction, causing gangrene. Or patient may have subclavian steal syndrome. What is subclavian steal syndrome? Now you can see this is the brachiocephalic artery. From this, the common carotid artery is arising. Then this is the subclavian artery. From subclavian artery, vertebral artery is arising. The subclavian and carotid artery, both of them anastomas in the base of the brain. What the anastomas is called? The anastomas is between the carotid and vertebral artery vessels at the base of the brain. What is that? Anastomotic, yes, good. This is circle of Willis, very good. So there will be anastomosis in the circle of Willis. Yes, good. So this is the circle of Willis. Here is the common carotid artery, and this is subclavian artery with vertebral artery. Suppose erythematous plaque develops in the subclavian artery first part. So there will be some occlusion to the blood flow to the upper limb. When the person is doing some heavy exercise with upper limb, then what will happen? More blood is demanded by the upper limb. Because of the block, the blood flow is not being adequately supplied through subclavian artery. Then what it will do is it will suck the blood through the collaterals of this circle of Willis. So the blood from the common carotid artery, which has gone into the circle of Willis, will pass through the circle of Willis and enter the subclavian artery because there is demand. So because of this demand, that means peripheral to the occlusion, whenever there is a demand, there will be vasodilatation. So because of this vasodilatation, the blood from the circle of Willis will pass through a reverse channel. That means through the vertebral artery usually should pump upwards, but now the blood is being sucked into the subclavian artery. And the upper limb will have no pain. But because circle of Willis is being deprived of blood supply, the patient feels dizziness, reeling sensation. Sometimes he may faint even. This is called subclavian steal syndrome. Steal means to take away. So this is called subclavian steal syndrome. So subclavian artery gives origin to the vertebral artery, which passes intracranially and anastomosis the carotid artery branches to form circle of Willis. When first part of the subclavian artery is occluded, there will be reversal of blood flow in the vertebral artery during exercise of upper limb, providing collateral supply to the upper limb. The patient experiences syncope or visual disturbances on exercise of the upper limb with the diminution of blood pressure on the affected limb due to stealing of blood from the brain by the upper limb via vertebral and subclavian artery. Just there are only 3 or 4 slides for clinical features. I will just tell them and I will stop it here because some of the students they asked me to stop the class at sharp 6 o'clock because today is they have to attend Varalakshmi Vratam. So I will just take only 2 minutes of your time. Mesenteric artery. If there is atherosclerotic obstruction of the mesenteric artery, then patients will have midgut ischemia. That means patients will have postprandial central abdominal pain. In severe ischemia, there will be gangrene of the small bowel. If there is atherosclerotic plaque over the renal artery, there will be renal artery occlusion producing hypertension. Coronary artery, it produces angina pectoris. In severe cases, myocardial infarction. Carotid artery, the patients will have in the initial stages transient ischemic attacks. Later, there will be hemiplegia in severe cases. Okay, these are the clinical manifestations of atherosclerotic obstruction to the various vessels. You must remember, atherosclerosis is a generalized disease process. Even if the disease manifests in the lower limbs or upper limbs, you must investigate for vital organ blood vessel supply, perfusion, by appropriate tests. So, in the earlier stages, there will be mild ischemia, which will be seen only on demand. Next, there will be rest pain and ulcers with color changes, absent pulses. Then there will be gangrene. So this can be applied to any organ in the body. Any visceral structures, if they are gradually being uprooted, first there will be mild features, later there will be infarctions. So this is about clinical manifestation of atherosclerosis. Any doubts? Any doubts, please? Okay. If you have no more doubts, I will close this session and we will continue the class tomorrow at the same time. Okay. Thank you. See you tomorrow. Wish you all good night.